Okay, so it's the right one that we've been having the problems with for this particular client. So we'll get you to just pick up your, that's your left leg. Yep, I'm right now. So just roll back for me. Done. Terrific. Now, when we're doing the Thomas test, really important that we just get a couple of things straight, and that is what's happening with the lumbar spine. So if this particular person's coming in and they've got lumbar lordosis, hyperlordosis, so an increased curve in that thoracic, that lumbar spine, we need to clear that out because we're not going to get a true indication of what's happening with the actual hip flexors, okay? It may indicate that we're obviously getting... So to do that, how I work out whether or not they've got that hyperlordosis is obviously that we're doing, we can do an observation, looking at their pelvis, but whether or not I can slip my hand underneath their lumbar spine while they're lying on the table, okay? So I'm lucky in the fact that I can't, I've got to push my way in there. That if, let's just say for instance that Cam did have a hyperlordosis, then I'd obviously have to flatten that out, okay? And then that's where he'd hold that, okay? So he's all right, he's not too bad. So I'm just going to put my hand in the nice curve of his lumbar spine and take it up until it flattens out on my hand. And I want you to hold that there, Cam, if that's all right. Beautiful. Okay, so we're looking at what's happening with our hip flexor, Iliocycle group. We're also looking at what's happening with the rec fem, and to a marginal degree what's happening with TFL. So if we're looking at a tight psoas, then obviously we're going to be looking at something like that. Okay, so it's above the parallel of the table. Now once again, this depends on the athletes and the people that you're treating. When I was working with the Australian Rules Footy Club, they needed to have probably about that much range, okay, in their hip flexors because they're running and they're kicking, so they need really good flexibility through their hip flexors. But if you're dealing with someone else that doesn't need that hip flexor, then you know something along the lines of just being parallel is actually acceptable, okay? So you have to manage it depending on what sort of athlete and what sort of person you're treating. Okay, if the leg's straight, it tends to point out, like it does a little bit with Cam here, then the rec fem is probably more the structure that's tight, and then if we're getting that lateral deviation away from the pelvis, the midline, then obviously the TFL is the one that's creating more of the tightness. And then sometimes we have the beautiful yes, yes, and all of them, okay? But you don't. You only see that from time to time. So he doesn't necessarily have a tight psoas from my point of view, but what I'm also more interested is what happens when I load it and when I stretch it. Do I get feedback straight away with it, meaning that it feels tight, or can I play with the range of movement? And that's how I ascertain whether or not it's actually quite tight. So I'm holding here and I'm just pushing down, and just let me know, do you feel a stretch at all or anything? Yep. Whereabouts do you feel that, Cam? So in this area here or down here? More on the groin. More on the groin, more here. So that being the case, what that indicates to me is that potentially he's getting really tight, and he is tight fascially in over at the attachment. So our iliopsoas comes down and it attaches into the lesser trochanter. Well done. 10 points. He gets another prize. Onto that lesser trochanter, and it's there that it can actually get quite tight. So that's where, when sometimes we've got people coming in with a tight psoas that sits up here, it's not necessarily the belly of the muscle that's tight, but it's at the attachment. So what we do here, and I might as well demonstrate this now while I've got him in this position as opposed to getting him back up again, is the technique to offload the attachment tightness. You all right with this? Yep. Okay, so what we do is we find the lesser trochanter, okay, the attachment. Shouldn't be hard to do. It's poking up because of the position we have it in at the moment. That's about it there, isn't it? Now what I'm doing here, is that better? You can see that? What we're doing here is just cross fibre work over the attachment, okay, for about 10 seconds. 2, 3, 4, 5, 6. How are you going with that?
It's the opposite of pleasant.
Yep. It stings. Relax, okay? Then push it down. Beautiful. So you usually will get about a good 5 degrees out of this change. Just hold on. All right, there we go. There, you're right. Okay, now we do this roughly around about 20 times. No, we don't. We do it 3 times. 2, 3, 4, 5, 6. Beautiful. Okay. See it's dropping away? Great technique. Great for footy players. 2, 3, 4, and cyclists. 10. Beautiful. Okay. That's good. Terrific. Now, also what we can do sometimes is we can also do some myofascial work through the top of the rectus femoris here whilst he's in this position. Yep. Sorry. You all right there?
Yeah.
You sure?
Yeah.
Okay. You're not going to do this on 85-year-old women, okay? They're just not going to handle this position real well. All right, so choose the people that you do these techniques to. They go, oh, I'm a bit tight through the front of the groin. Well, let's get you in the Thomas test. Here we go. So pick the clientele that you do these type of techniques to. Don't just because, yeah, I saw it at a case study, I can use it on everyone. Make sure that they can hold the position, they've got the strength and endurance to hold the position, and also make sure that it is a comfortable position for them to hold it, that it's just not irritating. I remember doing this technique on the case study the first time. I said, you know, I'm checking in with you, I'm saying, yeah, you're all right with this pain, you're all right with that? He said, mate, there's no way you can inflict more pain than I've ever had, so go for it. Okay, righto, that sets the benchmark there. Okay, so what I'm doing here is I'm just wanting to free up the fascial tightness that they can develop through. Okay. All right, that's good. How does that feel through there now, mate?
Yeah, it's hardly.
Are you getting any stretch or tensional load through there at all? No? That's good, and that's what you want. You want push down on the psoas, and there's no feedback coming back from it, okay? It just plateaus out. And I just wind it up a little bit and just go again. Okay, so the treatment sequence for him was bilateral quadratus lumborum. We cleared that out. Can I have this one? Okay, and just lift your head, drop your knees, and off you come. Okay. All right, you just stand up for a minute and I'll move this table back to our posies. Thanks, Cam. And I'll get you to lay back down onto the table for me, please, mate. Yeah, I can do the draping. It's like a magician's. Blah. Okay, now, bilateral quadratus lumborum treatment that we did in the knee. Yes, it was the knee case study. So that means side lying, clearing out both quadratus lumborum. We also, with this situation, we were doing our Iliacus and Tfl. I'll go through that again now for you. Do you want me to go through that just so that it's a quick refresher and it's in your mind? Now just remember with Tfl, if you've got someone coming in and they have a really aggravated, Tfl, meaning the fact that if just a small amount of palpation and you get a lot of resistance and you get a lot of pain referral, why is that Tfl switched on? Okay, why is it so aggressively tight? Why is it so aggressively tender? Usually it means because it's working too hard, because something else is not firing and working, okay? Most of the time you'll find it because it's those gluteal muscles that are overwhelmed, okay? So, wow, your TFL is tight. Geez, wow, your TFL is tender. Think outside the box. Why is it tight? Why is it tender? Okay, it's being overwhelmed. So, glute med, but we need to clear it out, and usually when it gets tight and tender, it'll restrict our internal rotation of our hip. Okay, so that's it, is it? Great. Okay, so we've got some restriction on this side. Let's look at the other side. Probably just a fraction better, but still reasonably tight. So to free it up, let's do the Iliacus. Now what we can do is I'll just get you to push up against any pain on that there. That's okay. So that's obviously we're looking at a test for loading up the hip flexor. Internally rotate the the leg, and can you hold that up for me? Hold it up so you can support it. Can you push in against me? Push up. I'll push down. Anything on that? Now if it's TFL's wound up, loaded or painful, usually you'll get a positive sign on that, okay? So just clear out your hip flexor, resisted hip flexion, and then TFL. Okay, so we're going to do just a little bit of work on Iliacus first. Now, there we go. How's that? That's better. Okay, so once again, we're going to sink in, pull back towards me. So I've got that Iliacus up against the fossa, and then just cross-fibering backwards and forwards. How's that feel there, mate?
It's all right.
It's all right, not too bad. Just hold your knee in there that little bit more for me, mate. That's good. All right, and then I'm coming backwards towards me. Okay, good. All right, now we're going to go through the TFL. Strip the length of the TFL, engaging the posterior fibres. So I'm pushing the knee over so I can pick up the posterior fibres of the TFL and all that fascia as well. Just looking into Cam's eyes. How does that feel? That's pretty...
It's a little tender.
It is a little tender, isn't it? Very tender, actually. Oh, okay. There's a small gold mine in here. Why is this TFL so sensitive? Okay. I think there might be some adductor in that. All right, what I'm going to just quickly do, obviously the client that I was seeing didn't have this, but we're going to do this quickly. We'll just clear out this Adductor Longus because I think he's a little bit tight through that adductor. We'll see what change we get off that. So I'm just in Adductor Longus there, push up against me. You'll see it pop up there. So we've got Adductor Longus there, relax, relax, relax. Off there, which is also really important, is our Abductor Magnus, which lies in through that area there. A giant muscle. If you ever get people coming in with hamstring range of movement restriction, straight leg raise stuff, and you can work on their hamstrings till the cows come home, you don't get improvement. Swap your focus to the Adductor Magnus, because I'll guarantee you that it's those Adductor Magnus that will be tight and restricting the range of movement for the hamstrings. In particular, the trigger points. Now the trigger points lie right below the ischial tuberosity, so it's in a reasonably provocative area. If we were to palpate them here, it's right up here. So it's a fair amount of informed consent with that. You need to know exactly why they're working there and where you're going to work. Okay? Otherwise, it can get a little bit confusing. Nice and red there, mate. Okay, that's certainly better. Okay, come back to that TFL. And you can see it there. Push up against me, Cam. You can see he's got a giant TFL. All right, relax. And that's primarily from racing. I'm just going to free up. So I'm going to work longitudinally over the posterior fibres. I don't know if you can see that. That's it. Can you just hold that knee down, sort of? That's it. Good, good, good. All right. Good. Okay, relax. Okay. All right, so that's that internal rotation. We can keep working through that and try and offload it. Now, TFL bilateral. So we'll also clear out the obers, but I want to go through the Glute Max with you as well. So we'll get you to turn over onto that side for me, Cameron. So Glute Max. Pretty important muscle, glute max, especially when we're talking about and treating sacroiliac joint dysfunction from a soft tissue point of view. Being a hip extensor, but because it has a sacral attachment, refers into the sacrum itself. As I said, it's a fairly good mimicker for sacroiliac pain, the glute max. The big muscle, obviously you can see it there. We're going to be trigger point probably about midway down the sacrum, just off laterally, and then we have two trigger points here just above the ischial tuberosity. Okay, so that's our glute max trigger point activity area. Glute minimus is up here, so we've got the anterior fibre. You can see his TFL sticking up there. Posterior fibres, and then up on the iliac crest itself is where the glute med lives. Okay, so we're looking glute med, glute minimus, and then glute max. So trigger points here for glute max, trigger points here for glute minimus, and trigger points for glute medius there. Okay, glute med, glute min, glute max. Everyone got that? Just a quick refresher so we all know where we're at. Okay, so the beautiful thing about glute max trigger points are you don't have to dig for them. It's right there. It's superficial, so we don't have to push down. If you're pushing down and through, then you're obviously aiming at a tissue deeper than the glute max, all right? So for whatever reasons, you shouldn't have to dig very much for those glute max. So if you just want to give me some feedback.
Yeah, it's
Kim?
right.
Yep, feels all right. So I'm working along the border of the sacrum, coming over a little bit further here. Okay, how are we going there, mate?
It's fine.
That's good. And because it's on stretch, if he had significant trigger point activity, you'll be able to find these trigger points quite easy. But Cameron seems to be not too bad. Feel all right?
Yeah,
Yep, good. Okay, come down, make sure that we clear out the two that lie just above the ischial tuberosity. There's our ischial tuberosity there. Flick over the hamstring attachment, come above. Adductor Magnus is about in up there. So we're going to come just at this lower portion here and pick up these Glute Max. Okay, so I'm coming in with an elbow. Oh, I can't do that, can I? Tender there? Yep. Okay, good. Do you normally say that to your clients? Good. Oh, why is that so good? Because they've got something to treat. That's why. Okay, so we clear out those series of, say, about 12 longitudinal strips through these muscles. Okay, that's good. And that's all we need to do. That's Glute Max out of the way. And we can do some fascial work, but I do that from the opposite side. Where I come off the greater trochanter, stabilise. I'm not using a pointed elbow, I'm using a broad, and then it's just take the tissue up towards him and then lock on and then strip through. How are we going here, Cam? No problems? Shouldn't be really painful, this. I know it looks like it's penetrating, but it's actually not, because the direction of my force is not down, but it's actually along the length of the tissue, okay? So I'm not trying to penetrate down, I'm engaging and then almost a sliding engagement. That's all right. Now, if you were to try and work piriformis, which is a deep muscle, then you're going to really struggle to get through piriformis because you've got all the superficial tissue on stretch, so it's pushing everything up and pushing you away from that. You can certainly try and work it through that, but you're not going to probably get much influence. Now, what I also like to do as well, because this is sacroiliac and we've got all the fascia around the sacrum as well, we need to clear that out. Now, what we'll do, I'll show you how we'll do that. We'll get you to lie onto your back for us. Now, this is a functional approach in the point, what I'm going to do is I'm going to wind up his external rotators and I'm going to try and work out where he feels tightness fascially. And then we'll work on that through the range of movement to try and free up his external rotation, okay? So, take the leg up into knee flexion, bring the knee across so you're over the midline, okay, of the body, and then bring in internal rotation. Tell me when you start to feel a stretch, Cam. About there? Yep. Now, whereabouts are you feeling that, Cam?
Just glutes.
Just glutes? So whereabouts? Here? About there?
Yep.
About there? Right, so can you hold that there? I'll get Cameron to hold that there for me because I haven't got another set of hands. And now I'm going to treat this area while he's got it there. You're still there? Yep. Okay, so you're feeling it around this area here or around further?
No, first place, yeah.
About there? Mm-hmm. Okay, all right. So I need to engage this area here. Okay. I'm on, I think it will be just off the edge of glute minimus actually at the moment, but it's fascially that I'm on. You're right there, you still got it?
Yeah, still got it, yeah.
Hang on, that's better. Okay. So I'm trying to challenge the fascial tissue here whilst it's on stretch. Okay, good. Because if you've got this anterior rotation, then the unfortunate thing is that it tends to load up all this fascia. So we're just going to do it again. Once again, I want you to tell me when you start to feel a stretch. Cam?
Slight stretch there.
Slight stretch there. Okay, that's good. Whereabouts are you feeling it now?
Still around glute.
About there?
Yep.
Okay, hold that there. Round there. Yep. Yep, okay. Breathing. Good boy. Okay, good. So you'll notice we're getting just a little bit more range with this as we go. Each time we should just pick up a little bit more range of movement, even if it's just passively at the end of the range. Because what it means is if we can get any increase in range of movement, it's obviously going to make a difference in function. Just the smallest amount of change in range of movement can make a big difference in function. Yeah, that's pretty good. I'm going to struggle to get any more than that. That's twist your leg off. All right, that's good. So you understand the process of winding it up, hold it in that position, then locate the area where the restriction is, and then work through that range, okay? But then you have to keep retesting to see where the next segment is tight, okay? And then free that off and then keep going. All right, okay. Now, I mentioned beforehand in his objective assessment when we were looking at him structurally that he had an anterior rotation and also that upslip. And the idea of, I was talking about an upslip is being that there's an iliocycle fixation. So there's a technique, an MET technique that I use to try and free up and gap. It's almost, they call it a gapping technique. So when we locate the PSISs, we go to the PSIs, so we just come down just off the PSISs and we get them to bend forward. And if they've got one side that's going up higher than the other, then that indicates that that side may be the fixation, okay? And the idea is that we get them on the table, sitting, and we do it again. And basically the idea is that sometimes you can have an upslip, but it might be a tight hamstring. So you basically got a hamstring that's pulling down on one side of the pelvis, and as you get bending forward, it's obviously restricting the range of movement there. So to take the hamstrings out of the picture, we get them and we do it sitting and see if it's still positive. Okay. Now the gapping technique, I'll quickly show you, it's pretty simple. We do is we pick up the leg. Now you've got to make sure that they don't have any knee pathologies or instability in the knee when doing this, or God forbid some sort of, they're after a hip replacement. So we're bringing the leg down, okay, and onto the table, okay, and then we just add a little bit of force as we do it. So we do about 3 or 4 of these, 2, 3, 4, 5, okay. So we just give it a little tug just on the end range. So as it comes down here, we just do a movement. It's not a manipulation, there's no high velocity thrust or anything. And then back into hip flexion and press down and just got our hands at the back of the sacroiliac joint, just to see if there's movement back in that area there, okay? Now, usually that'll be enough just to gap that area and stop that fixation, but then you have to obviously treatment. If they've had the upslip for a long time, more than likely what happens is they'll have a structural restriction. So you send them off to the chiro or the physio or whoever you use to treat structural restrictions. But you've got to make sure that that's cleared out. All right, we've done that. So we've done our Thomas test, our Glute Max, Glute Med, obviously QL, iliolumbar ligament. Okay. How many here of you, just hands up, have treated the iliolumbar ligament just out of? Yep, good, okay, all right. Just lift your head, mate, and then we'll get you to spin over onto your front for us if you could. Beautiful. Okay, so I was taught this technique by a physio colleague of mine. Oh, I think it was my second year out from study, And it's been a fantastic technique, and it's helped numerous clients. Now, the idea is usually I've got anyone who's visited my clinic, I have heaps of pillows, my best friend's pillows. I don't necessarily use a bolster like this, but I'll have a pillow, probably a reasonably thin pillow. Just slide it underneath the leg that you're going to do the iliolumbar mobilisations on, and it just puts the hip into extension. And then grab your towel, and we move to the iliolumbar ligament. So, okay, let's just revisit the anatomy. Coming down, so the buttock fold starts there, so our L5 is going to be around about there. Okay, iliac crest comes around here. Palpate your iliac crest. Coming down, L5 is there, ilium's there, so the ligament's going to fall in that space. It occupies that space right there. And it's in here, that's where we do the work, okay? And it's here that they'll have the pain. Okay, so you've got to palpate in that area, and you'll elicit obviously a reaction. Now what I do first is I do some deep longitudinal stripping first. Just put a little bit of Myolube there. Good. There's your surgery. Maybe you can see that there, but that's where he's had the sural nerve release. So, you've got bony prominence on one side, bony prominence on the other side, fall in between the two, and you're in that little gap there. It's like a little pocket almost, like a V pocket. Comes down like that. Okay, so pick up the bottom of that V pocket and work up towards. Sorry about this, but to get onto it. Okay, that's better. So I'm doing some longitudinal gliding along the length of it. Now, if they've got an iliolumbar ligament that's really tender, you'll get a whole range of feedback. Sometimes they feel like pain running down the inside of their hamstring, up their back, into their buttock, even into their groin. Sometimes it's different for every person, or it'll just be really painful there. And then once we've finished some longitudinal gliding, then we just do some grade 1 mobilisations over that ligament. Okay, just like that. Just a mild bounce. Like so. And once they've had this work done, and they've had that iliolumbar pain, they'll get back up, and they should feel really good through that area almost immediately. But, as I mentioned before in the case study, the next day they might be a bit tender. Not unusual. Okay, there we go. So once I've cleared that out there and done that, take this out, and I'll do some work just on that glute med. Okay, so our glute med, there's our iliac crest coming right around the top there. Glute min's going to be here. Okay, so the trigger points for our glute med are going to be here, right around the iliac crest, up high. Okay, not down here, up here. You all know that anyway, don't you? Sometimes you've just got to recheck. Okay. Any tenderness there?
No, it's okay.
So, Yep. So you can, the good thing about glute med is that you can run your fingers backwards and forwards over the tissue and you pick up the torque bands really easily if they're there, because there'll be those big flicking sensation. Get a bit of a twitch response sometimes. What about there? Yep. That's all right? Yep. Tender? Yep. And I come around a little bit further, and then we're just at the edge of glute minimus there as well. Yep, that's good. So pick up all the laxity in the skin and engage. How's that, Cam?
Not too bad.
All right. Okay, all right. So that pretty well much sums up the treatment for this person. Obviously, we get them back up. Now, after I'd done the iliolumbar ligament, because as I mentioned beforehand, when he'd get up and then push himself out of the seat to get up. He found that he didn't have to do that pushing sensation after the iliolumbar mobs, which was a really good sign straight away that obviously we were on the right structure and we were going to get the right sort of change for it as well. Retest some of his signs and symptoms. Obviously, depending on the nature of the sensitivity around in his glutes, he was going to get some post-treatment soreness. As I said, the day after, symptoms went back up to 80%, and then we had a complete resolution on that second day, and didn't see him for, I don't know, 2-3 months. He came in with just some lumbar stiffness and stuff. It was the next time I treated him. And he's just come back this week, so, and treating for the same scenario again, I'd say. But this particular time, he'd just done some extensive work. There were some really, really large slabs. He'd been doing some commercial concreting. So it meant that they had to dig out a lot of the footings and everything themselves, so it wasn't just only the concreting, it was the digging, and it was a whole range of other things. So that means he was getting in and out of trenches. A little bit harder for him to get out of trenches than it is for us, just because of the ankle problem. He's basically got to throw the leg up, and you sort of can't bend your ankle to get up in and out and put weight on it like we can. So yeah, so obviously that overwhelmed the area.
So for everyone, thank you very much for coming for the weekend. I think it's been a real success. It's been great. So many thanks for coming along. And in the future, we're planning on doing some other case study work. So hopefully we'll have you along again, where we have an opportunity to hear about some of the real life experiences that Stuart comes across in clinic. Yep. And the ways that he can work with them, and hopefully impart some knowledge onto you guys. So thank you all very much for coming.
Also, can I just say something?
Yeah.
Can I really enjoy the feedback that we get from these, because this is the first time we've done the case study series. Obviously, we want to try and make it more interactive. If you have any ideas or things that you thought that we may have missed out on, or you think that could improve it, we'd certainly love to hear it. I'm reasonably passionate about this type of presentation because it gives you the real life flavour of when you're out there treating, and more so, like I said at the very start, the decision making process that you go through. What should I treat? When should I treat it? How do I treat it? And what are my outcomes? And I think it's really difficult out there as therapists because you basically close the door and you're in there with your clients and that's it. There's not much interaction apart from you and your clientele. So when you come to one of these things, obviously you want to try and learn as much information as you can that you can then utilise in there as well. I don't perceive to know it all either as well. I'm here struggling and fumbling through the clinical experience just like you guys. But if you can set yourself limitations and knowing what you're good at and what you and the outcomes you get for your clients, you're obviously doing the best that you can. But at the end of the day, these resources are meant to try and just help you be better therapists, and makes me a better therapist doing these things as well. And I feel really passionate about this area. And when I approached Dave about this and doing this, I think it's an area where we sort of lack a little bit, especially because there's not much mentoring in our industry. So you come and do your undergraduate studies, and then we ship you off out into the big wonderful world of clinical, and then you're sort of like lost for 5 years going, oh, what do I do here? Who do I refer to? And just getting to know the pathologies that you work on as well. And you can come to these sort of these seminars and actually rehash what you've learnt, and then go, yeah, okay, now I think I'm on the right track, or yeah, no, I didn't realise I could do that, or you know, I mean, if you take one thing away from these workshops or these seminars, you know, and obviously you've got your money's worth as far as I'm concerned. So, yeah, but would really appreciate any feedback you have, constructive, you know, whatever form, shape it comes in is always good. So thank you very much for being.